Welcome back. We're going to jump in now to kind of the second segment of this. What DeWar in her text calls, I think the name of the chapter is "Issues with the U.S. Healthcare System," or maybe "Issues with U.S. Health System." I don't remember right offhand, but it's that first chapter in her text. And as I mentioned earlier, her text was written in 2010, maybe to some extent a little outdated, but I think it's a very good basis for what we're going to do in this class over the next few weeks. So, plus it was a text that I was able to find out on a free site, and there's no out-of-pocket cost for buying your textbook, which I always liked, at least when I was in graduate school. So that's kind of the approach on why we're going to use it. And even if I find a few things that, that may be a little, I guess, maybe not up to date, we'll take care of those as we go along. Want to quickly talk about it, and I mentioned it last time in kind of my overview of health economics. It's the financial coin. It's the struggle over the healthcare dollar, and just financial coin. You've got, basically you got two sets or two groups of individuals going to each other. You've got the health plan, you've got providers, and they're both struggling. Providers wanting to maximize revenues, health plans wanting to minimize costs. Also, the government, because they fall on the payer side, they're wanting to minimize costs. And if you think about, go back again to your old micro classes, and what's one of the distinguishing characteristics about economics that distinguish it from other social sciences, and there's basically three of them. There's economics focuses on opportunity cost. The second one, which is what kind of relates here, is buyers and sellers are interested in, they're self-interested. Utility drives their decisions. It's they're trying to optimize something. Producers trying to optimize revenue. Consumers trying to minimize costs. So, and then lastly, most individuals are making choices at the margin. So then we'll get into a little of that as we go along. But what we want to focus on now is this financial coin. You've got, on one side, you've got consumers, whether it's governments, health plans, private payers, whether it's, employer groups that have decided not to actually go with the health plan, but to try to manage health care on their own. And, they're trying to minimize costs and trying to, they say minimize costs and maximize quality. And we'll get into the issue with quality a little later, but that's a little different because quality is really difficult to quantify. So it makes it a little tough to kind of maximize quality. And then on the other side, you got the providers. They're driven by profit. They're driven by revenue. They want to provide that utility not only for themselves, but for their family. They want, a better way of life. They went into medical school for a reason. They spent 4 years and maybe in medical school and 1 or 2 years in an internship, maybe a couple of years as a resident. Then if they specialize, you went into like neurology, cardiology, something, you start adding up those years. So they've invested a lot of time and effort to get that medical license and practice medicine. So they're out there trying to maximize their income stream or their income flow on an annual basis. And so on kind of the payer side, again, you've got federal, you've got state, you've got local government agencies, you've got health plans, you've got employer groups, you've got private pay. And then on the other side, you've got providers. And when you start looking at providers, there's a multitude of different categories of providers. You've got physicians, so individuals that get to put an MD by their name, or you've got physicians that get to put a DO by their name. So they've gone to medical school to learn how to practice medicine. You've got physician extenders, you've got, PAs, you've got nurse practitioners, You've got individuals with, with master's degrees, especially in social work. You've got ancillary providers, laboratory, radiology, anything that, when you're talking about, ancillary or physician extenders, that kind of picks up, physical therapy and those types of individuals. And then you've got on the hospital side, you've got these huge behemoths that, think of Meharry, or think of a Baptist there in Nashville, or think of Vanderbilt. I mean, these huge hospitals and huge complex systems that are providing inpatient care and outpatient care. You've got ambulatory type services, ambulatory surgery, those type services. And then you've got pharmaceutical. Pharmaceutical is a huge drain on the healthcare marketplace because of just the sheer number of pharmaceuticals when the physician, writes a script in their field. But it's a drain on the healthcare system. And then lastly, you've got this struggle with physicians. You've got, physical type healthcare providers, and you've got behavioral type healthcare providers. So there's always been a little struggle between those two kind of broad categories of providers. So that kind of sets a stage on your provider community. See if we need, and I think we touched on a lot of it. Supply and demand issues. You've got, government intervention. The government always thinks they know better on how we should live our lives, or how we should spend our disposable income. And so you've always got this government intervention going on. Then you've got, as I said earlier in Errol's article, you've got uncertainty with the incidence of disease, uncertainty with the results of your treatment, your efficacy of your treatment. You've got uncertainty on the provider side when it's, you're trying to estimate demand. You've got uncertainty on the consumer side when, you can't get out and kick the tires on the product before you buy it. So there's just uncertainty, this umbrella of uncertainty just across healthcare. And that's what we're going to try to diffuse some of this uncertainty, or we're going to try to develop some ideas on how to diffuse this uncertainty going forward. And then Dewar launches in and she talks about the dysfunctional healthcare system. And if you've ever tried to access especially our current healthcare system, I think you would tend to agree with her. The last time I went to my primary care doc, they don't want you to talk to anybody at the office. Everything has to be done on the internet. So you have to get on the internet. You have to try to figure out how to schedule an office visit on, some of these systems that seem really archaic, even though they're supposed to be the latest and greatest to improve customer satisfaction. From my, experience, they're not that customer friendly, from my perspective. And so you get it scheduled and you get this little nasty note, make sure you bring your driver's license, make sure you bring your insurance card. If you've got a co-pay, co-insurance, deductible, you got to pay it up front. We're not going to provide services to you if we don't get our money up front. And and then you get this little thing says, and you better have your behind in the office 15 minutes ahead of time. Okay. So my healthcare provider from where I live, it takes me 30, 45 minutes, maybe an hour sometimes to get there, depending on traffic here in Atlanta. So, you go out, you get in your car, you're using, gasoline to get there. You are taking time out of your day. You're talking about, man, here you're talking about opportunity costs. You're going to spend, it usually takes me from the time I leave home till the time I get back, it usually takes me between 2 and 3 hours. So that's opportunity cost of those 2 to 3 hours that I could be doing something else that I really enjoy. But anyway, you go down there, you get to the doctor's office, you go in, even though you've registered and provided all this information on the internet, you go through the same thing with them. And then you go sit down in a waiting room that, you're sitting in there and everybody's sick, especially in the winter. People are coughing and sneezing and probably would have been better off if you just stayed at home. But anyway, and of course, my doctor usually runs about 30 minutes late. And, I found over the years that healthcare providers don't understand that the patient's time is valuable. To them, their time's valuable. They want you there 15 minutes ahead of time, but it's okay for them to be running behind. So anyway, it's a extremely dysfunctional system, and that's just to get into the doctor's office to receive services for your ailments. Then on top of all of that, you've got the billing and the payment, and usually the provider can't bill accurately and the health plan's going back. It is just an extremely dysfunctional system, and it's one that needs to be more customer centric, because if I think if it was more customer centric, it would probably be a lot easier to navigate the system. There is no central government agency. There's, again, lack of coordination. The government will, especially on Medicare and Medicaid, they will provide information in the Federal Register. And if you've ever tried to get in, go to the Federal Register to glean information from it, well, good luck with that, because the Federal Register is written in governmentese, and so some kind of language that maybe everybody else understands, but it's extremely difficult to get information from the government, from the Federal Register, especially with CMS driving Medicare and Medicaid. It's technology and acute care driven. They are the 800-pound gorillas in the healthcare space. The most costly healthcare service that you're going to receive is something that is technology driven, or if it's especially in an acute care setting in a hospital. That you get here in the United States, especially, it's average, it's high cost service, and I don't want to say undesirable results, but unpredictable outcomes. There are imperfect market conditions, as I talked. There's a lot of the assumptions of the competitive market that the healthcare marketplace doesn't, function within. It's dominated by the private sector, and people look at the private sector, and that's where most of your services are provided. You've got some VA facilities that are staffed by the government. You've got military treatment facilities that are under the auspices of the Department of Defense. But for the majority of it, it's a dominant provider sector driven healthcare space. And you've got for-profits, you've got not-for-profit, and I can remember the last job I had at a health plan. It was a not-for-profit. It's Blue Cross Blue Shield plan, and everybody, when I first got there, and I came from United, which was an equity-based profit, for-profit driven health plan, and everything was efficient because they were, driven by earnings per share, because they had to keep the shareholders happy. But, you get the Blue Cross Blue Shield, and it's like, I had one of my managers said something to me. I'd been there a couple of weeks, and it said, "We're not for profit. We don't have to worry about making a profit." And I'm thinking, what planet are you on? They may be not for profit from a tax perspective, but they want to make money. They have to make money to stay in business. They have to, by state, states have certain laws. You have to have reserves built up in case something like COVID hits. So it's the mindset in this private insurance. I don't know. Sometimes it's a little disconcerting to talk to people. And then you've got, at the end of the day, you've got all of these market goals, for-profit goals on the provider side, and it's butting heads with, social justice. There's a real conflict there. So it's, multiple organizational forms. You got, different types of players that have gone through. And, there's always this quest for integration and accountability. And I think that's why you're seeing a lot of these health systems, a lot of these hospital systems over the last few years, starting to pull things together, starting to consolidate resources, trying to become more efficient. trying to become or trying to develop teams within this hospital system. You may have a team across half a dozen hospitals or half a dozen medical groups. You may have a team that does all the medical management for them. You may have a team that does all of the network management, negotiates contracts, helps set the rates for the providers. Everybody's trying to, specialize. Again, Adam Smith, if you read any of his articles, he was big on specialization. So you have trying to efficiently combine these resources. If you think, those of you that live in Nashville, you've got, HCA is located in Nashville. That's where their headquarters are. And again, HCA owns, a multitude of hospitals across the United States. So they are specializing in what they do, managing, hospitals and providers. So you see that a lot. There are concerns in the healthcare community or in the healthcare space talking about costs. And cost is completely out of control. They're talking about quality. Quality is extremely difficult to estimate, to forecast, to predict, and we'll get into it a little later. And you're talking about access. There's a drain on services, and some academics argue that it's these social non-market forces that are causing the drain on services. Back to my primary care doc, if I wake up on Monday morning and let's say I feel like I've got the flu and I call to get a doctor's appointment, the chances are slim and none that I'm going to get a doctor's appointment that day. I'll get on the system and there's some office slots available, some visit slots available. The first one may be, Thursday. Am I going to feeling that bad with the flu, or I think I may have COVID? Am I going to wait till Thursday? I can self-refer out to urgent care, which you're talking about a crapshoot. You go to urgent care, that's a real crapshoot. But again, it's access and it's drain on services. Does that mean that if you go back to your old micro classes, does that mean that that demand's out of whack? Does it mean there's not enough supply of office visits? I think it depends on where you're located. And if you think access to care is an issue now, just read the newspapers and pay attention to the news. There in certain places that were underserved with one hospital in town or within a county or within a geographical area. You see these hospitals going out of business. They're filing bankruptcy. They're closing their doors. There was one it seemed like last week, I can't remember where, but it was in North Carolina somewhere, that was, shuttering their doors. And I think they'd given all the employees notice that seemed like it was October the 1st, they were going to cease to do business anymore. So that's going to impact access. We're a system in crisis. Some, especially academics, argue that it's we're decreased access to private insurance, increasing number of uninsured. Think about everybody coming across over the southern border. How are we going to provide healthcare goods and services to that group of individuals? You've got individuals in the United States, have lost their jobs. COVID was a complete drain on our economy. And one of the offsets of COVID is individuals that either quit their jobs, lost their jobs, didn't go back to work for one reason or another. And they're sitting out there now. Maybe they're sitting out there with no health care. Maybe they haven't gotten access to Medicaid. Maybe there's no mechanism in the area where they live that they can get access to goods and services that, especially as it's being supplied to the uninsured population. You've also got coverage gaps. You may have health insurance, or you may think you have a good health plan, but once you start trying to access that health plan or that benefit plan that you've either bought yourself or your employer's provided for you and you're paying a premium to the provider for, or to the employer group for, you won't know whether there's gaps in that health plan, and you start trying to access the system, and you start getting those replies that, well, this isn't covered by your health plan, but if you want to go ahead and get that service, you can get it for bill charges. So, it's talking about, just the gaps in health plan. And then again, go back to the uninsured drain on services and the uninsured drain on the taxpayers. Dewars talks about, and we'll get into it in some of the later chapters, but she starts to differentiate. She views it as its health, your health status, the scope of your health, and then there's the medical care. So if you have issues with your health status and you have to go see medical care, that's a service provided for medical care. And then kind of your health status and medical care goes into forming just the health care that she gets into in her text. So it's not a bad way to break it down, because everybody is born with a certain health stock or with a certain level of health status. And it's either how our parents help us take care of that health status, or once you get to be 18 or 21 or leave home or whatever that age is, then you become independent and you have to take care of that health status on your own. So how you take care of your health status, and that's going to drive how much medical care you need. And the combination of health status and Medicare ends up kind of under the umbrella of healthcare. See what else she talks about. She gets into, and I said we'd get into a little later, but the meaning of quality is elusive. Is it process? Is it an all-encompassing of the entire experience of going to the doctor, or is quality nothing more than being driven by the efficacy of your treatment? When I worked at United, we would interview members there, that had gone to the doctor, and you'd start asking them about quality, and they'd start saying, well, the waiting room was clean, and his office staff was nice. They had free water for us. There was a coffee pot there. We'd get a cup of coffee. They had TV on to entertain you while you were waiting. I really liked, the doctor when I liked his bedside manner. But very seldom did they say, or they try to equate quality with the efficacy of that treatment. So that's why I think, the meaning of quality is elusive. And then she starts talking about mortality, morbidity, adverse incomes, complications, especially in a hospital. They talk about hospitals and acquired conditions. And so you go in, from my perspective, the hospital is the last place I want to go, because even if you're treated well and in the efficacy of your treatment plan works to your advantage and it's a positive outcome, you're still exposing yourself to the potential for acquired conditions. So, they return them as they, typically call them HAC, hospital acquired conditions. So I don't know. It's a real issue when we're talking about quality. You've got AHRQ, it's the Healthcare Research and Quality. It's the agency for that. They have scorecards. It's a joint commission that's trying to provide information on hospitals. There's some websites you can get on. I think Leapfrog's one of them. Can't remember the names of the others, but if you get into Google and you start typing and you start talking about, quality indicators of hospitals and their reports, it'll give you quality indicators and scores and help you try to be better informed. But still, it's an imprecise process. You've got HEDIS, which is the Healthcare Effective Data and Information Set. NCQA, you've got National Committee on Quality Assurance. HEDIS is a data set that if you decide to go down the route of being a medical economist, you will become extremely familiar with HIMSS and extremely familiar on how it's put together and how you can use the information to help predict, to help forecast, to help estimate. For better, for worse, again, it's the best. It may be the best source of information or healthcare data we have, and it's still not perfect. If you're a healthcare economist and individuals are concerned, especially in the healthcare system, on how you're doing comparative metrics. Some health plans, some government agencies look at things, on a time series basis. They look at it, daily, monthly, quarterly, yearly, month over month, quarter over quarter, year over year. Or they may look at, cross-sectional data, looking at multiple providers, services, socioeconomic classes. And so you've got healthcare economists that are generating these metrics, government agencies generating metrics, and you're trying to compare these metrics, and because the methodology is different, it makes things extremely difficult to compare, because when you're talking about time series versus cross-sectional, it can get confusing in a hurry. And then you get into health insurance. She starts talking about health insurance, and it's you're talking about shifting risk and uncertainty. So you as a consumer are willing to pay somebody to accept financial risk and the uncertainty of both your episode of care and your efficacy of treatment. And if you're an insurance company, a lot of them will typically break it down. There's a medical loss ratio, which it's the ratio of the cost of the expenditures that they paid out. Most health plans, a lot of health plans are kind of, shoot for like 80 to 85% on the medical loss ratio. Then you've got some administrative costs, figured in there. And the administrative cost is, enrollment, it's claims processing, it's medical management, it's senior management, it's middle management, it's staffing, cost of the building, talking about administrative kind of all rolled into that. And then you've got profit. So if you are a health plan and you're getting $1, because let's just make it simple, you're getting $1, and if 85 cents of that dollar is spent on healthcare expenditures and healthcare for your members, that leaves you 15 cents on every dollar to take care of the administration piece and what's left over for profit. Healthcare organizations, whether it's on the provider side or the payer side, they're really no different than let's say your corner bakery when it comes to profit and loss. If you look at your corner bakery, you've got fixed costs. You've got the building. You may include staff in the fixed cost. You've got variable cost, electricity, water, whatever input you have to buy. Flour, sugar, salt. I'm not a baker, so there's some inputs that you have to buy to make the muffins or donuts or whatever you're making, and then whatever you have left is your profit margin. And again, it goes back to your micro classes. It's fixed cost, variable cost, profit. How all of that ties together, and healthcare is no different. And one of the ways that that health plans and employer groups are starting to drive the financial risk sharing is they're trying to work risk sharing agreements with the consumer, with their employees, with their members. It can be done with a high deductible health plan. Is kind of the flavor of the month now, but in the past it's been and still is to some extent co-pays, co-insurance, and deductible. Deductible means that you're going to pay X number of dollars for all your healthcare services before the health plan kicks in and starts picking them up. Co-insurance, it may be, let's say your health plan is an 80-20 plan. And the co-insurance is the 20% that you pay, and the 80% health plan pays for your visit to the doctor's office. So you pick up the first 20% of it, the health plan picks up the other 80% of it. Or as I mentioned earlier, you can have copays. Mine happens to be $10 to go to see my doctor. There are some health plans out there that, and mine happens to be one of them, that there is no copay for my annual visit, for my preventive health care. Am I getting a colonoscopy? Do I get my cholesterol checked on a quarterly basis? Do I have an annual physical? All of those are free for me. I just are free for me from the aspect of it's out of pocket dollars that I'm paying to a provider. I'm still having to pay for gas. I'm paying for wear and tear on my vehicle. I'm paying the opportunity cost of something that I could be doing that's more enjoyable, certainly, than going to the doctor. But again, it's kind of what we're held with, for better or for worse. And then she spends a few minutes talking about it, and I think because she'll get into it a little deeper in some of the other articles or some of the other chapters, starts talking about health status. World Health Organization defines the health status as a complete state of physical, mental, social well-being. It's not just the absence of disease. And again, where we discussed earlier, you've got your health stock or your health status, and then you've got medical care, and the combination of those two ends up driving healthcare. You've got individual health, and a lot of it is age, sex adjusted. There are disease morbidities. There are, deaths, mortality rates. So there are some rates out there. If you're a male, 40 to 55, there are some probabilities, actuarial derived probabilities that say, you have this, you have this probability of getting a certain morbidity or disease, your mortality rate. If you're following these categories of care, they can estimate your mortality rate. And, again, it's adjusted by age and sex. She talks about for a few minutes, talking about life years. You've also got, she just touches on it briefly, talking about a composite health score. And then she launches into population health. And a lot of the population health, especially mortality, is age, sex adjusted. It can also be racial, ethnic, geographical. She talks about premature death, talking about a target age. Everybody's got a target age. And then she tries to wind up as, talking about, it's impossible to use strict, and she calls it neoclassical approach to healthcare. And, human behavior, it's responsive to incentives and constraints, healthcare costs. She said even in 2010, dysfunctionality is increasing. And I'm not sure it's as bad now as it was in 2010. It's still dysfunctional. There's a lot of automated, there's a lot of mobile device applications that seems to help streamline the process of going to see a physician. I'm not sure how much, how much is customer oriented, but at least it's there, and if individuals want to use it. But healthcare costs continue to be out of control, and unless we get our arms around it and make healthcare more customer centric, I think we're going to have some real issues. And again, a lot of these topics, this is just her first chapter. A lot of the topics she'll touch on in the future chapters, and we'll get into some more details in some of these as we go along. But that's going to wind up chapter 1-4. And chapter 1, we've got it in module 2. But if you have any questions, don't hesitate to comment on the videos, send me responses, send me questions on the videos, and we'll touch base again as we roll into chapter 2. Thank you.